All right, welcome everyone. I'm very pleased to introduce Susmita Kashikar-Zuck, who is, as you see on the slide, Professor of Pediatrics and Clinical Anesthesiology at the Division of Behavioral Medicine and Clinical Psychology at Cincinnati Children's at the University of Cincinnati College of Medicine. She also is the Associate Director of PORTICO, which is the NIAMS-funded P30, stands for Pediatric Pain Research Center. Oh, that's different. Actually, she's the Associate Director of the Pediatric Pain Research Center and Associate Director of PORTICO, which is their NIAMS P30. So she has lots of responsibilities, as you can see. So Susmita is a pain psychologist. She's a clinical psychologist and has been doing a lot of really good work in understanding kind of the factors associated with pain in kids with musculoskeletal and other conditions, as well as leading some interventions to try to improve pain in kids with musculoskeletal conditions. So I'm looking forward to hearing her talk. And one fun fact is that Susmita and I actually overlapped at Duke. I don't even want to think about how many years ago, but I think you were doing your fellowship, and I see Dr. Keefe on here, who I think was worked with both you and me around the same time, maybe. And I was working on some pain-focused trials with Dr. Keefe and others. So have known about Susmita and her work for a number of years and excited to hear what you have to tell us today.
Great. Thank you so much, Kelly. It's really exciting to be able to present to the wider group of P30 CCCRs today. And what I'm going to talk about today is non-pharmacologic treatments for chronic musculoskeletal pain in children and in teenagers, which has been my area of interest here for the last 25 years. So greetings from the lovely city of Cincinnati, which is on the Ohio River. This is looking over from the Kentucky side over the Ohio River to the Cincinnati skyline. This is Cincinnati Children's Hospital where I'm at, and I'm in this middle building on the second floor in an office that is not facing here, but facing the back. So that's where I'm talking to you from today. I have no disclosures, conflicts of interest to report related to the presentation today. My research is funded by the NIH, by the NIAMS, by the Childhood Arthritis and Rheumatology Research Alliance, as well as our research foundation. Just since we have a lot of center folks here, I thought I would do a very quick introduction to PORTICO, which is the Pediatric Musculoskeletal and Rheumatology Innovation Core Center. The PI on this grant is Dr. Hermina Brunner, who's on here today. And hi, Hermina. And so I co-lead the administrative core of PORTICO along with Hermina, and we have a wonderful methodologic core. I think Michael Wagner, who is our informatics associate director, is maybe on today. Hi, Michael, if you're there. And we also have a patient assessment resource core that really specializes quite a bit in imaging and novel assessment techniques. And we focused primarily on three areas in juvenile arthritis, in childhood onset lupus, and juvenile fibromyalgia and other chronic musculoskeletal pain conditions, which is really what I want to talk to you about more today. My area of research is really primarily in this area. We have a number of exciting activities going on as part of PORTICO. And some of the things we've come up with is a novel shared decision treatment portal for juvenile arthritis, an informatics platform for EMR-based data sets for access by our investigators, innovative fMRI tools, and creating a pediatric ultrasound score for quantifying the burden of synovitis in children with GIA. Those are just some examples of the things we are doing. For the purposes of the talk today, I will talk about my research specifically in cognitive behavioral therapy and exercise-based interventions for complex musculoskeletal conditions in children and adolescents, primarily juvenile fibromyalgia, which is where I have been doing most of my work. And then really, I know, the methodologic core is hosting some of these talks. So as we go through, I want to highlight and talk about it a little bit more about some of the pros and cons of self-reported versus performance-based measures of outcomes in behavioral trials. So I've been thinking a lot about this as we've been doing our trials, and I'll tell you some of the work that we've published in this area that might hopefully help provoke some thoughts about how we design our outcome measures, and also talk about how psychological constructs like the fear of movement and physical performance measures are actually the psychological constructs can influence even our performance-based measures. And then just talk about, just more generally, how some of this knowledge can be used to create more precise treatments for musculoskeletal pain in children. So some of you are very familiar, chronic pain, which is pain greater than 3 months, is quite common, surprisingly common actually in children. Most of the times, the pain conditions are related to headache or abdominal belly pain, and musculoskeletal pain is really quite common. And within that, about 3 to 5% of school-age children, which doesn't sound like a lot, but that is a lot of children, report having widespread pain, that is pain in multiple body areas. And after puberty, chronic pain is more prevalent among girls than boys. So these numbers have stayed relatively stable. And in a very recent paper, Christine Chambers and her group just published another a paper in Pain on the prevalence of chronic pain in children, and the numbers stayed pretty similar. The burden of chronic pain in children is enormous. It interferes with their daily function, their school functioning, peer relationships, participation in sports, family impact, and high healthcare utilization. And so I just kind of put some snippets of papers we've published in the past relating to the high burden of pain. In 2020, the World Health Organization published their guidelines for the management of chronic pain in children. And really, a key portion of this is really their very strong statement that children with chronic pain and their families and caregivers must be cared for from a biopsychosocial perspective. So they really encourage this very holistic view of managing chronic pain in children and not treating pain as simply a biomedical problem. So in the WHO statement, they reviewed the literature at the time and based their recommendations on the existing trials at the time. And so the recommendation was that physical therapies may be used alone or in combination with other treatments, but the certainty of the evidence was quite low. This is physical therapy, certainly something we use clinically in our care, but in terms of the quality of the evidence out there, the quality of the evidence is relatively low. Possibly the best evidence is for cognitive behavioral therapies and related psychological interventions such as acceptance and commitment therapy, other behavioral therapies and relaxation therapies, which may be delivered either in person or remotely or in a hybrid fashion. And there's moderate certainty for that evidence. And as far as pharmacologic management is concerned, as some of you may be aware, the drugs that are typically used for management of pain in adults are often not labeled for use in children. And so there is usually off-label use of these medicines, and there aren't a lot of trials for chronic pain management in children. So that is certainly an area of much need as well. So many of you are familiar, and of course, Dr. Keefe is here, being the pioneer of the cognitive behavioral therapy approaches for chronic pain. Cognitive behavioral therapy is a type of psychotherapy that was originally developed for the treatment of depression, and it was really focused on identifying thoughts and feelings and behaviors and sort of working with individuals to identify and modify their thoughts around the particular symptoms they were having. And it's one of the most commonly used psychotherapies in contemporary practice and has been modified very effectively for a number of anxiety disorders, for the treatment of insomnia, and most certainly for the treatment of chronic pain. And in the 80s and 90s, became a very standard component of multidisciplinary care for pain programs in adults, which is where I initially received my training, and really became familiar with the concepts of CBT. And we started to apply this to pediatric pain in the early to mid 1990s, but there were very few well-designed trials of CBT in children. So just to very briefly, for those of you who are not as familiar with CBT, we usually start, these are usually approximately 6 to 8 week sessions. We tested an 8-week protocol where we begin with a very sort of developmentally appropriate modified version of explaining how pain works in the body and how chronic pain is different from acute pain and injuries by providing the patient and their family a type of neuroscience education. Used to be called the gate control theory of pain. It's some modifications. We spend time with parents, teaching them how to be a good coach for their child, because that is essential when you're trying to do any sort of behavioral intervention with youth. We then focus on some of the very key essential aspects of CBT, starting with relaxation training and other behavioral techniques, using distraction techniques and guided imagery, learning how to pace activities, and then the cognitive restructuring techniques and problem solving and maintenance techniques. So when we initially started this, it was an individual program, which was seeing a therapist 1 time a week for 8 weeks. And that is very similar to other programs that have been used. So in 2018, Emily Fisher and Tanya Palermo's group published the Cochrane Review of Psychological Therapies for the Management of Chronic and Recurrent Pain in Children. And they looked at the impact of psychological therapies on pain intensity and disability, which are typically the outcomes we look at. And they found that there was some pretty good evidence for psychological therapies being effective for both pain reduction and disability immediately post-treatment, and also for reduction of disability in the long term. However, when they evaluated the actual trials, for the quality of trials, the quality of the evidence was judged to be low or very low, because many of these trials had methodologic issues and study design problems with high risk of bias, because either their randomization scheme was not very well explained. There were small sample sizes. The masking was not routinely done, and there was no reporting of adverse events. So the trial quality was quite low. So in looking at the treatments for musculoskeletal pain, where we are at right now is that the medications that are used are primarily for symptom management, so using anti-inflammatory or analgesic medicines, or some low-dose antidepressants or atypical antidepressants, or some anticonvulsants are used as well. When you're treating youngsters with chronic pain, oftentimes they have some difficulty tolerating some of these drugs, and there really are not any long-term efficacy studies of the medications. However, that's where we're at, and those are the current treatments that are currently used. Cognitive behavioral therapy, based on a trial we did, I'm going to just explain it very quickly, has good effects and durable effects. And there was one small study that showed aerobic exercise could be beneficial in pain for children with musculoskeletal pain. There are several clinical programs that have published their outcomes with intensive exercise and cognitive behavioral therapies as part of inpatient or intensive day programs, and they have found some beneficial effects. but those are not, of course, controlled trials. So just very briefly, this was a trial we published in 2012, which is like 12 years ago, I can hardly imagine. But this was one of the first larger clinical trials, very specific to musculoskeletal pain condition. And for those of you who have treated juvenile fibromyalgia, it is a very complex musculoskeletal condition with not just widespread chronic pain, but also other symptoms like fatigue and sleep difficulties and dysautonomia and multiple other somatic symptoms, as well as difficulties with mood and anxiety. So when we tested a CBT protocol, so we compared a cognitive behavioral therapy protocol, 8-session protocol, with fibromyalgia education. So that was really more on just healthy lifestyle and healthy habits. Same number of sessions. We found good evidence that CBT was effective both at post-treatment and at 6-month follow-up, with continuing improvements in disability reduction over time. And pain intensity tended to come a little bit later, but there was a small improvement, which was significant, but a small improvement over time compared to the fibromyalgia education group. So one of the things we did, so coming back to this whole idea of assessment of outcomes in trials, the measures that we typically use are self-report measures, or PROs, patient-reported outcomes of pain and disability. One of the other things we did as part of the trial was use accelerometry to just take a look at their physical activity levels. And this was just more on an exploratory level. And what we found was, although cognitive behavioral therapy was effective in getting people to report that they were functioning better, the kids were getting back to school, getting back to some of their activities, but there was really no change in their participation in moderate to vigorous physical activity. And so we started to do a deeper dive into physical assessments to look at movement and how they were moving and what may be some of the reasons why participation in more vigorous activity, which is sort of typical for that age group, was so difficult for them. And so one of the models that has been long been known in the pain literature has to do with the fear of movement and the fear avoidance model of pain, where physical activity is associated with the thought that pain is going to increase if the person becomes more active. And so how does one break that cycle? And really, to look into that, I began to work more with our sports medicine colleagues and those who do injury prevention research to really think about how biomechanics and movement competence can be improved in order for people to feel more comfortable and more competent with their movement, and then thereby avoid activity a little bit less. So the first thing we did, of course, was to really try to look at the movement characteristics in children and adolescents with juvenile fibromyalgia, and we did document that they had lower strength and altered functional biomechanics in their movements. So we did gait analysis, we did a drop vertical jump task, which is something that is often used in, it's a standardized task used in sports medicine research. And so we can calculate their, the ground reaction forces as they land. We can look at the lower extremities and, the kinetics and the kinematics of their joints as they're going through these various movements, and looking at it in more detail, and also looking at lower extremity strength, looking at knee strength, hip strength, and so on. So all those studies really guided us towards developing an intervention where we worked with our sports medicine colleagues to develop a specialized exercise program where we use something called neuromuscular exercise training, which is a progressive training protocol where we really focus on their gait, their posture, their core strength to build their capacity for physical activity and exercise, and combine that with psychological coping skills. And we intentionally made this a group-based program because hearing from our patients, they really wanted more support and social engagement while they were learning new strategies and new exercises. And of course, we always include parents for the behavior modifications and learning to be a good coach. And very briefly, for those of you who haven't heard about the Fit Teens intervention, which is fibromyalgia integrative training, they are 16 group-based sessions held over 8 weeks. And we have 2 trainers, a psychology and an exercise trainer that implement the protocol. And so they do components of CBT as well as the neuromuscular training as part of each of the sessions. And really, we do 2 weeks for neuromuscular training. The first 2 weeks are focused on the isometric component of how to hold a movement. The concentric portion of neuromuscular exercise, which is learning how to create movement, the eccentric or how to resist movement. And then finally, the last 2 weeks are on learning the full functional movements. So it's really very graded and walks them through to improve their movement ability and reduce injury-prone types of movement as they go along. So these are some of the pictures from our actual groups with our psychologist leading them through some of the breathing exercises. We initially did our motion capture in the 3D motion capture lab. This is them doing some of the neuromuscular training in a group-based format. And this culminated in a trial that we have just recently completed, where we tested this combined intervention, which is the Fit Teens intervention, with CBT alone. So these were group-based sessions, but they only got the CBT component, and compared that with graded aerobic exercise, which is what they might typically do in physical therapy, is start out with graded aerobic exercise at a low level and slowly build them up. So it was an 8-week treatment. We completed post-treatment assessments, and we followed them all the way up to 1 year. The 3-month follow-up time point was our primary endpoint. And then we continued to follow them, and they had periodic booster sessions in between to maintain their exercises and the trainings they had learned. And this was a 6-site trial. So we, Cincinnati Children's, actually it was 7 sites ultimately. We had Kansas Children's Mercy, Boston Children's, Indiana, Connecticut, nationwide in Columbus, Sick Kids in Toronto, and Cincinnati Children's participated in this trial with Emory researchers, Greg Meyer and his group supporting us on the biomechanics and the physical aspects of the study. Now, interestingly, this trial began, we enrolled our first participant in January of 2018, and we got hit by the pandemic smack dab in 2020, which was close to halfway through the trial. So in an effort to fill the gaps in the literature, we did an enormously careful description of the rigor of our study and published our protocol for the clinical trial with details on our eligibility, how we screened, our randomization, masking, selection of our endpoints, details on treatment fidelity, adherence, adverse event monitoring, all of this. And then we had the pandemic. So we had to pivot very quickly and make all our treatment manuals so that the treatment could be delivered remotely via video telehealth. And it took us about 4.5 months to basically transform everything while still keeping all the components of the treatment, including the exercise components, and essentially replicating the same trial, but now in remote format. And so we published our protocol adaptations as well for the remote format and continued the trial, and were able to successfully complete it. So I am super proud that we were actually able to complete this trial despite all the disruptions. So ultimately, we randomized over 300 patients to the 3 treatment arms. And of these, a little over 42%, so about a little less than half were randomized prior to the onset of the pandemic. So they received the treatment in an in-person format. And then about 60% were randomized after the onset of the pandemic, and they received remote treatment. So we actually ended up having a trial within a trial, if you would, and were able to basically use the same treatments in 2 different delivery platforms. And interestingly, we were very successful at maintaining our attendance at treatment sessions. In fact, many of the families reported that during the pandemic, this was really a lifeline for the children to be able to interact with their peers and be able to work with trainers. One of whom was a psychologist, one was with exercise, so they could keep active and they could talk about emotional things that were affecting them as well at the time. So we had extremely strong retention, with over 90% completing the entire 8-week treatment phase and 80% being retained at the 3-month follow-up. And even at the 12-month follow-up, we were pretty close to like 70-75%. And so this is our consort flowchart of the study. And as you can see, we had about even numbers randomized to each of the treatments. Trying to see if I can get my arrow here. Here we go. And so we had 291 out of the 317 that completed the active phase of treatment. And that was about even. We had a little bit more dropout in the graded aerobic exercise arm throughout. The fit teens and the CBT arms had very, very strong retention. It was not significant, but there was a slightly greater dropout. And this is something we think had to do with the fact that graded aerobic exercise, which is something we knew all along, was probably going to be a little bit less tolerable for them than the other 2 treatments. Nevertheless, about 70%, more than 70% hung in there with the treatment. And really, it had to do with the group aspect. They were very engaged with their group-based treatments. So these are the main results. So this is like very hot off the press. And our initial hypotheses were that we would find stronger results in terms of functional disability, which was our primary outcome. So that is the FDI. We were anticipating that the fit teens group would show slight stronger improvements in the FDI compared to the CBT or the graded aerobic exercise group, and potentially also stronger improvements in pain. What we ended up finding was that there was strong reduction in functional disability, and that was a main effect for treatment across all 3 groups. And when we compared our fit group with the CBT arm and the fit group versus the GAE arm, we did not find the interaction effects that we were expecting to find. So that was a little bit disappointing. I should point out that this was the intent to treat analysis. And so this was a very complex design because we had a multi-level design whereby the individual patients who were assigned to groups were within cohorts, within sites. And so we had a very complex statistical model that we tested. And after all the variance was accounted for from all the multi-level aspects of the study, we were not able to show differences between the 2 groups. The good news was that the behavioral as well as the exercise-based treatments do appear to have a strong impact on functional disability, and the improvements in pain tend to come a little bit later. So the green and the blue lines are the fit and the CBT groups. And you can see that they're tracking all the way through. Number 7 is the 6-month follow-up. They're tracking very similarly across time. The graded aerobic exercise group, in terms of reduction in disability, doesn't really show a whole heck of a lot of change, but they also have a reducing pattern over time. And even though this graph looks like there is a difference between the groups, the intent to treat analysis, because of the standard error, they do overlap. So you don't see differences as far as statistical significance goes. And over time, you see a slow reduction in pain intensity over time. Time number 4 was our primary endpoint, which was the 3-month follow-up. And at that point, interestingly, when you look at the 3 groups and you look at clinically significant improvement in FDI, so that is an FDI score reduction of 8 points or more, you find that the proportion of patients in the CBT and the fit teens arm are quite similar, whereas the ones in graded aerobic exercise are at 3-month endpoint, not showing clinically significant reduction in functional disability. But then later, that over time, you see some of that, the groups kind of converging together. So what we also did was look at a number of other emotional and functional factors that we assessed at each time point. And again, you can see this very consistent pattern of the CBT group and the fit teens group showing very strong reduction in pain catastrophizing. And really, this was a remarkable difference from, it was like a 10-point reduction overall, which is really clinically meaningful. You do see a reduction in catastrophic thinking with the graded aerobic exercise arm, which is the yellow one here. Also, again, not as strong, but you do see similar types of findings across the measures. So with pain interference, with the PROMIS pain interference measure, with fear of movement, you see improvements across time, across all of these measures, including depressive symptoms. Again, stronger effects for the fit teens and the CBT group, not as much with the graded aerobic exercise group, but by the 12-month time point, there are reductions happening over time as well. And so there does seem to be a generalized improvement across the group. It sort of happens potentially a little bit quicker in the fit and the CBT groups. We also documented adverse events throughout the study, and teens with fibromyalgia tend to have lots of adverse events. They were not mostly related to the study, but out of all the adverse events, 47 were judged to be possibly, likely, or definitely related to the treatment. And so there were about the same number of adverse events in the fit and the CBT arms, a little bit higher in the graded aerobic exercise arm, and that had to do with slightly higher reports of musculoskeletal pain and increases in pain that were mild and mostly temporary and resolved quickly. And there were no serious adverse events that were related to the study procedures or the treatment. So the good news is that these are generally very safe treatments in the over 300 participants that we had enrolled in the trial. So just the summary here is that our psychological and exercise-based interventions, and I should have mentioned earlier that we did a sub-analysis where we compared or the in-person versus the video telehealth version of treatment delivery, and essentially there were no significant differences in treatment, in outcomes based on the method of treatment delivery. So that was another finding of the study that was quite interesting, is that we can effectively deliver these treatment. They're still in real time. You're still working with the trainers in real time and with the group, but you can deliver these treatments quite safely and effectively in this way. And we found treatment effects were still prevalent even after one whole year after the end of active treatment. So there is maintenance of treatment gains. And similar to some of our past studies, we always find that the functioning returns quicker than the improvements in pain, which starts to really show up only after the 6-month follow-up period. So it's sort of this delayed indicator of improvement. The graded aerobic exercise arm was not significantly different than fit teens or CBT. So there are certainly some people that will benefit nicely from graded aerobic exercise as well, but it was at a slight disadvantage, and that was because I think there was a few more people tended to drop out of that treatment or have some difficulties with tolerating the graded aerobic. And it was really a very mild graded aerobic exercise. We were not really pushing them extremely hard. I wanted to also note that once our paper and everything is published, we will make our treatment manuals available because physical therapists are actually already working with patients. The neuromuscular training is something that is relatively easy to pick up, and it will be available in manualized fashion, and of course our CBT manuals. We are doing more assessment of our physical assessments. What I presented to you was all of the patient-reported outcomes. So here is what I want to talk about sort of in the next portion of time we have here. So I was lucky to be part of a working group that was led by Tanya Palermo and Gary Walko on updating recommendations for patient-reported outcome measures in clinical trials for pediatric chronic pain. And this was published last year, and it was the culmination of a four-step process where we determined the domains that were important to measure in pediatric chronic pain trials with input from all stakeholders, including providers and youth with chronic pain and their parents. We did Delphi polls with pain experts and patients with lived experience of pain, as well as did an extensive review of the literature of existing measures. And then we had an expert consensus conference where we ultimately picked the best measures. And again, these were the patient-reported outcome measures. So, you will have these slides available to you, but this was published last year in Pain with the measures of all the important domains that we identified, which had to do with pain severity and pain interference with daily living, their overall well-being, their emotional functioning, physical function, and sleep quality. So this was really all the domains we looked at, and there are multiple measures that are quite well validated now, including PROMIS measures. Possibly the physical functioning measure is something that has been on my mind and we've been working on, and I think we can really think about how to do better with some of our assessments, and I'll go into that in just a minute. So as I said, PROs are the most commonly used outcomes, which is entirely appropriate in chronic pain, with pain being a subjective experience. So self-report of pain intensity is really the only way to know how much pain a person is feeling. We have a good number of validated measures that are brief, easy to administer in trials. They're very practical. Many of them are very face valid, make sense to patients and to providers when you score them, what that actually means. Some of the disadvantages, as with any patient-reported measures, they can be affected by reporter biases. So, it could be biases, but it also could be perspective. So if you ask a child or an adolescent to report their pain and you ask the parent to provide a proxy report, you will, of course, get a slightly different view of the child's pain experience. There could be contextual effects. Are you seeing the child in the hospital versus assessing them in the home or in a different context? Recall bias could also be one of the factors. And again, self-reported functioning is important, but may not provide the full comprehensive picture of the impact of pain. So let's talk about performance-based outcome measures for a minute, because as I told you, we've been doing a lot of work in looking at measures of fitness and strength, gait, movement patterns, and some of them have been used well, particularly in the adult literature, for interventions of physical therapy, exercise-based interventions. And the advantages are that they could provide a more, and I'm putting this quote in quotes, a more objective assessment of functioning. And I'll tell you why in a second. But looking at the physical impact of musculoskeletal pain, these are very quantifiable ways of doing it. And they may be a more sensitive indicator, obviously, of the ability to perform tasks. And it is a more visible way to demonstrate improvement in treatment. Like, these are the things you can do. The disadvantages of using some of these performance-based measures that it doesn't really address the person's subjective own experience of pain and the impact of pain on their lives. So you still need the self-report measures for that piece. And another disadvantage, it's not a disadvantage, it's just not something we think about a lot, is that a person's psychological state, that is their affect, their motivation, and their effort, is also something that affects their performance on these objective measures, right? So if a child is fearful of movement or is feeling very fatigued and so on, you are not going to necessarily get the most accurate measure of what they can actually do when you have some of those psychological influences. So just things to think about as we design our trials. So one of the examples I wanted to give you is sort of method of measurement, right? So typically daily diaries are the preferred method in research studies. Those are not usually used clinically. In clinics, we typically ask patients, can you tell me how much pain 0 to 10 you had in the past week, right? So we have retrospective recall, and you have in research studies, they're like, well, that could be influenced by recall biases, so we should do daily diaries, and that is the preferred method. And sometime after the trial began, we started thinking about this more, and we decided to collect both measures from patients. So for over 200 patients, we were able to collect both 1 week daily diary measures as well as their retrospective recall of pain in that past week. And as you can see, and this was at different points of treatment. So at the baseline point, at the end of treatment, which is at the end of the 8 weeks, and then at the 3-month follow-up, consistently retrospective report of their pain intensity was higher than their daily diary measure. So this has been shown in some other studies as well. The thought is that perhaps as people are recalling pain in the past week, maybe the teens were attending more to sort of their high pain days, so it was somewhat influenced by that. But we haven't actually tested this, so we don't know exactly why this happens. But this is something that could sort of influence our interpretation of trials a little bit. So the differences are small, the patterns are similar, the correlation between the measures is moderate to high, but it's just something that we need to keep in mind as we think about our measures, because there are some slight differences. Now, this whole idea of performance-based measures and self-report measures, we, again, as part of a sub-study within the trial, we were looking at how patients report of their own functional disability, their ability to do things in daily life, was related to things like their fitness measures, like the Harvard step test or a 6-minute walk test. And you can see that pain intensity with regard to correlations with the Harvard step test, for example, or the 6-minute walk test. This was a significant correlation, but it's pretty small. And similarly, you have the relationship between these measures as well as, you can look at the psychological measures, and you can look at how these are related to the fitness and the two fitness measures and the psychological assessments of FDI. So FDI, here we go. FDI is this one, number 6. So this is the relationship between the functional disability score as reported by the patient and their ability to do a 6-minute walk test or a fitness index. So what this tells us is it's really getting at something a little bit different, but still important, right? Because we want to know what is their ability to do a task versus their report of how much they can do in their daily lives, and perhaps look at it from different perspectives. And as far as our trials go, be able to look at things in a slightly more comprehensive manner. A little while ago, I mentioned to you that psychological constructs, and in this case, the fear of movement, as measured by the Tampa scale of kinesiophobia, how does that affect movement patterns, right? So these are very objective measures. So we looked at the drop vertical jump task, and we looked at their kinematics in this case, and kinetics. And we were looking at the relationship between those who reported higher fear of movement versus those that had low fear of movement. And there were actually significant differences. They were subtle, but they were significant in alterations in their movement patterns. So there did seem to be, again, this is cross-sectional, but there does seem to be some relationship between these psychological factors like fear of movement and movement mechanics. So again, bringing us to the overall view that we can get really important information from different sources of assessments using the person's own report versus their performance and multimodal assessment. So I would advocate for us to really think about using more multimodal assessment to get more rich information as we design our future trials. And this can also help us identify subgroups and identify treatment responders and look at treatment targets from different angles. And that could help us then design more precise interventions and really look at specific areas or particular mechanisms and how those might result in improvements in disability and pain outcomes. So I feel like we're at a point where we can really begin to get more precision-based approaches and look at these trials in a manner where we can design trials to be more targeted at the specific outcomes that we want to look at. And I will wrap it up at this point. Thank you for listening. These are some of our patients from our actual trial, and of course a big thank you to the enormous teams that have helped in all of these studies and the support from the NIH, from PORTICO, and from our research foundation. So I will end it there and open it up to any questions.
Thank you, Susmita. That was great. I don't see any questions in the chat yet. Oh, okay, I see Dr. Keefe, you have your hand up. Please go ahead.
Yeah, I wanted to thank you, Susmita. That was a terrific presentation. Particularly appreciated that you shared your outcome data in this format, hot off the presses, and all the methodological refinements in the study. They're just really impressive. And there's a lot of interesting stuff to look at. One of the questions I had is about, I'll put out two questions. So one is, I think right now there's some controversy about pain as the primary outcome in studies of behavioral treatment. So I'd sort of like your take on that. The second thing is, I'd encourage you looking at this relationship between recalled pain and pain collected in diaries. We published a paper years ago that found actually the people that were most accurate in recalling their pain were people who were psychologically distressed. We did a similar thing of compared their daily diaries. And in that particular study, it wasn't that they actually had more daily pain. So it wasn't that, but if they were distressed, depressed, any of the psychological measures, they were actually better at recalling pain patterns over the past week and so. So it suggests if you really want a nice readout using retrospective report, you might want to get people who are distressed when you're going to get more accurate reports. But you might take a look at how your psychological measures collected at the time of recall relate to the discrepancy between pain recall and at the through the diary. But anyway, the other issue is really pain as a primary outcome. What's your take on that? I know people vary quite a bit.
So yeah, I can tell you my personal preference where it comes to non-pharmacologic and behavioral treatments. My preference, and actually in the 15's trial, I had initially proposed pain and functional disability as co-primary outcomes, and was actually seriously encouraged by members of the review committee to pick disability as the outcome. And actually that to me makes complete sense, because that is specifically what we target as part of our treatment. And so we help them try to understand their pain and the impact of their pain, but the focus is on function all the way through. And so we really do not talk as much about pain as we do about their preferences and values and getting back to their typical daily activities and reducing the impact of pain. Now, I do believe it is important to measure pain, because eventually, and this has happened time and time again in our clinical programs, in my trials, pain will eventually start to go down, but we really seem, so I think there's a timing aspect to this in terms of being very transparent and telling the families that we treat about what to expect first and what not to expect happen in the initial stages of treatment, so that they have realistic expectations about when this pain. So I think there is a time factor here that I think we need to talk about. So the choice of the specific outcome, I think, depends on A, the particular type of treatment that you are your target and what you're planning to do, and B is the timing of when specific things. So depending on when your primary endpoint is. So if I had said my primary endpoint is 6 months and I will power on a pain outcome, that may have been a reasonable approach, but I do not think it would have been useful to power on a pain outcome at immediately post-treatment, because they're still learning those techniques and applying them, and it takes a little while for that to take impact. So that is the approach we take in all of our clinical programs in educating families on when to expect improvement in what. And so I believe that is potentially a realistic way of looking at it. The one thing I did want to say is that I think we do need to do a better job of trying to see if we can get pain improvements sooner, but I think we're just not at a point, at least in the pediatric pain world, that we have more physiologic or neurobiologic targets where there's a lot of work going on in trying to understand sort of the neurobiology of chronic pain and potential quote unquote druggable targets. And if we make improvements in that area, I think we can start powering more directly on pain outcomes. But I think we need to get there, but we need much more mechanistic biologic research first before we get to that point. But from where we are at right now, I think disability would be my top choice, or pain-related functioning would be my top choice. But that's my preference. I guess that's still out there. Thank you.
Susmita, I have a question for you. In your trial, you also saw some nice improvements with all of your interventions. Do you have plans for moving forward with any of those or that line of research?
thank you for asking, because I think about that all the time. So actually, there is so much data from the trial right now. There are two directions I'm thinking about. One direction is that there is a lot of expressed need. This was specifically in teens with juvenile fibromyalgia. There are patients with secondary chronic pain conditions. So this is more of a primary pain condition, but we do have a great need in our patients who have arthritis and lupus, who also develop secondary chronic pain, that I believe we can maybe not deliver it in quite the same way because their needs are a little bit different, but start thinking about modifications. We've already done some work in the CBT space with patients with lupus, but thinking about integrating exercise-based programs that could really helping them use a Fit Teens kind of approach. So that is sort of my Fit Teens 2 idea that I'm thinking about right now for children with rheumatic diseases, because they have some different physiologic and some different phenotypic features that we would need to modify it for. And then also the other aspect is I really want to start looking into treatment responders. So if we have improvements overall, okay, so what are some of the common versus some of the distinct elements? So I want to look at things like we've collected information on the social cohesion of groups. I want to know what it is about group-based treatment in general that help with helping people within their coping efficacy and things like that. And I want to look more at responders versus non-responders and who responded better to one type of treatment versus the other. These were all the overall intent to treat analysis. And I have a lot of thoughts about intent to treat analysis for another day. But I think there's more, that is the gold standard for trials, and that is what we did. But I think there are a lot of sub-analyses we can do. And also, we are waiting on the biomechanics analysis to find out what happened specifically with the Fit Teens group that was similar or different than the other groups, and looking at some of those outcomes. So we're at this transition point right now where we are sort of doing a couple of different lines of research moving in from that area.
Thank you. That all sounds great. I mean, this is clearly needed, really important work. So we look forward to what you all do next.
Thank you.
And we are at the end of the hour. So we will close here, but I want to say thanks again, Susmita. That was a great talk, and we appreciate your time.
All right.